cover these 50 topics, 50 questions out of the our predictor book, and I'm pretty sure that you are going to have a good strike rate with these questions, right? So without further ado, let's start. The very first question that we have is, we have a preterm infant who was born 72 hours ago, right, through normal vaginal delivery, and the delivery was uneventful. The baby is breastfeeding well, but the mother notices that there is yellowish discoloration of palms and soles. Whenever you notice this yellowish discoloration of palms and soles, it is definitely a pathological jaundice, right? And the examiner is also telling us that the total serum bilirubin is in the phototherapy range. So which of the following mechanism does phototherapy act by? And we have three options: configural isomerization, structural isomerization, photooxidation, all of the above. So what do you think would be the correct answer over here? So what is the correct answer? So phototherapy, yes, the blue light that the child receives, it works by all of these mechanisms: photooxidation, structural isomerization, and configural isomerization, also known as photoisomerization. But remember, the most important mechanism out of all the three is structural isomerization. That converts your bilirubin to lumirubin. Another question that they ask is which wavelength this blue light is giving, right? So the wavelength of this blue light is 490 nanometers. They also ask about the distance of this lamp from the baby. So remember earlier, the distance was mentioned as 30 to 45 centimeters. But now in the recent edition of Ghai, it is mentioned that this should be as close as possible, right? As close as possible, but definitely we have to make sure that baby does not get too warm, right? We have to avoid hyperthermia, because there will be a lot of heat given to the baby by this light. So as close as possible, but keep a close watch on the temperature of the baby. Baby should not get too hot, right? So this is about phototherapy. So yes, you all are correct. The correct answer here is option D, all of the above. Right, moving to the next question. We have a 5-day-old neonate who is born via normal vaginal delivery. He weighs 2.8 kg. He was discharged on day 1 of life and brought to the emergency with fever, poor feeding, and lethargy. Temperature is 39 degrees Celsius with sunken eyes, depressed spontaneal. Mother also has decreased milk production. So you are suspecting neonatal sepsis, and you send a sepsis screen. Which of the following parameters is not included in the sepsis screen? The options we have are total leukocyte count, absolute neutrophil count, eosinophil count, or CRP. What do you think? Which one of these is not included? Yes. So the clinical stem here gives you a scenario where you think that there are clinical features of sepsis. Also, risk factor of sepsis is there. Mother has decreased milk production. So what do you think? What do we go for? We go for a sepsis screen. And what are the components of sepsis screen? Which of these is not a component? Yes, option C, that is absolute eosinophil count is not a component. Let's revise sepsis screen. So whenever there is clinical features or risk factors that are suggestive of neonatal sepsis, you go for a sepsis screen. And what are the components? Total leukocyte count, absolute neutrophil count, IT ratio, that is immature to total neutrophil ratio, micro ESR, and CRP. Right, total leukocyte count less than 5,000, ANC less than 1800, IT ratio more than 20% or 0.2, micro ESR more than 15 mm per hour, and CRP more than 1 mg per deciliter. Right, and we need at least 2 abnormal values to say that the sepsis screen is positive. So nowhere here is eosinophil count, right? We are only having neutrophil count over here. So total absolute eosinophil count is not included in the sepsis screen. Option C is correct. Ayush is right. Amit is also right. Right, so option C, absolute eosinophil count, is not included in the sepsis screen. Then let's move to the next question. We have a diabetic mother with us who delivered a baby at 32 weeks of gestation. So two risk factors. There is a diabetic mother and also a preterm baby. And the baby weighs just 1300 grams. Baby had a weak cry, respiratory rate of more than 60, retractions and grunting. Surfactant was given in the NICU. All statements are true regarding RDS except ऑप्शन ए, RDS can lead to cyanosis. True. Respiratory distress अगर बहुत ज़्यादा severe होगा तो there will be cyanosis. This is true. It is treated by administering 100% oxygen. So we never give 100% oxygen. Oxygen always has to be titrated. और RDS में तो main management is initially CPAP and then giving surfactant, right? So this is wrong. It is common in babies born to diabetic mothers. Again, true. RDS is common when in the babies or the infants of diabetic mothers. Why? Because of the hyperinsulinemia, the surfactant maturity is affected, right? Surfactant mature neopatha because of this high level of insulin. So it is definitely common in babies born to diabetic mothers. And the fourth option is it occurs in infants born before 34 weeks of gestation. Again, true. Preterm babies में ही हम देखते हैं. This is again true. So which is the false statement over here? Option B, right? Riyajalam, you are right. Harish is also right. This is option B. So moving to the next question. We have a full term 38-week baby who is delivered by C-section, and the baby did not cry at birth and required resuscitation. Right? So at 6 hours of life, baby also developed seizures with blood glucose of 35. Which of the following is not a risk factor for hypoglycemic seizure? तो एग्जामिनर ने हमें क्या दिया? एक फुल टर्म बेबी है who did not cry और resuscitation भी required था, मतलब पेरीनेटल एस्फिक्सिया का रिस्क भी था इस बच्चे को, और 6 hours of life पे आपने हाइपोग्लाइसीमिया और सीजर भी डॉक्यूमेंट कर लिया. अब वो पूछ रहा है इनमें से कौन सा रिस्क फैक्टर नहीं है हाइपोग्लाइसेमिक सीजर के. तो पहले आपको पता होना चाहिए कि रिस्क फैक्टर्स क्या होते हैं हाइपोग्लाइसीमिया के. बहुत सिंपल सी बात है. देखो हाइपोग्लाइसीमिया कब होगा, ब्लड शुगर कब कम होगा? पहला, छोटा बच्चा है ना, प्रीटर्म अगर बच्चा है या वेट उसका कम है तो ऑब्वियसली स्टोर्स कम है तो हाइपोग्लाइसीमिया के चांसेस ज़्यादा होंगे. बड़ा बच्चा, लार्ज जेस्टेशनल एज, उस केस में बच्चे का डिमांड ज़्यादा है, इस वजह से हाइपोग्लाइसीमिया के चांसेस होंगे. इन्फेंट ऑफ डायबिटिक मदर, अगेन उसमें हाइपर इंसुलिनीमिया है, उस वजह से चांसेस ऑफ हाइपोग्लाइसीमिया ज़्यादा होंगे. अपार्ट फ्रॉम दैट सिक बच्चा जो निकू में है, सेप्सिस है, बर्थ एस्फिक्सिया है, ये सारे रिस्क फैक्टर्स हो गए. राइट. अपार्ट फ्रॉम दैट कोई अगर जेनेटिक प्रॉब्लम है ऑफ हाइपोग्लाइसीमिया तब भी होगा. अगर बच्चा पैरेंटल न्यूट्रिशन में है तब भी होगा. मॉर्फोलॉजिकल आईजीआर है तब भी होगा. राइट. सो लेट अस रिवाइज द बेबीज एट रिस्क ऑफ हाइपोग्लाइसीमिया. सबसे पहले छोटे बच्चे, राइट. बर्थ वेट लेस देन 200 ग्राम्स, 2000 ग्राम्स. Prematurity less than 35 weeks of gestation. Small for gestational babies. On the other hand, a big बच्चे, large for gestation age babies, infant of diabetic mothers. अगर mother was taking drugs like oral hypoglycemics, beta blockers, morphological IUGR, sick child, congenital form of hypoglycemia, baby on parental nutrition, ये सारे ही रिस्क हैं. तो अब ऑप्शंस देखते हैं. सबसे पहला ऑप्शन बर्थ एस्फिक्सिया. तो बर्थ एस्फिक्सिया तो डेफिनेटली एक रिस्क है. स्मॉल for gestation age is again a risk. Maternal diabetes again a risk. Post-term infant is not a risk, right? So which of these is not a risk factor? It is post-term infant. Okay, we'll continue in English, no problem. Vinay is right, Ayush Shukla is right. The correct option is D, post-term infant. Moving to the next question, we have a full-term 37 weeks baby who was delivered through C-section. The baby did not cry at birth and was non-vigorous. Neonatal resuscitation was performed and the baby was shifted to NICU. On examination, you notice that the reflexes are sluggish and you are suspecting hypoxic ischemic encephalopathy. You do MRI. Which part of the brain is involved in these cases? Periventricular area, basal ganglia, hippocampus, parasagittal area. What do you think is the correct answer over here? सिंपल बताया हुआ एग्जामिनर ने कि HI है और कौन सा पार्ट इंजर होता है, कौन सी ब्रेन इंजरी होती है टर्म बच्चों में जो पेरिनेटल एस्फिक्सिया की वजह से. व्हाट डू यू थिंक, क्या कौन सी इंजरी होती है? यस, अमित, शुभम. ओके. So a lot of you are saying basal ganglia. Shubham is saying basal ganglia. Vinay is also saying basal ganglia. Harish is also saying the same. Wrong. The brain area that is affected is parasagittal area. Basal ganglia affected होता है connectors में. right? Very high level of bilirubin when they cross the blood-brain barrier and cause kernicterus, they damage the basal ganglia. HI में parasagittal area affected होता है, parasagittal area, right? So let us revise the brain injury that you see in term and preterms. So term babies में major cause of brain injury is your HI only, perinatal asphyxia. तो perinatal asphyxia में क्या हो रहा है? ऑक्सीजन कम हो रही है, right? ऑक्सीजन लेस हो रही है, hypoxic injury हो रही है to the brain. So watershed areas would be affected. watershed area कौन सा होता है? parasagittal area. sagittal आपको पता है midline में होता है, तो उसके आसपास parasagittal area, right? So which of the parts would be affected? My lower limb would also be affected, upper limb would also be affected. So this child in future will have quadriplegia, right? Spastic quadriplegia. So term babies, hypoxic injury, you see spastic quadriplegia. On the other hand, preterm में the brain injury is intraventricular hemorrhage. So around the ventricles area involved होगा. So primarily lower limbs involved होंगे. We have spastic diplegia, right? So this is about the brain injury. And the third brain injury connectors we discussed, their basal ganglia is affected. और basal ganglia जब affected होगा तो future में ये बच्चा dyskinetic CP होगा, dyskinetic cerebral palsy, right? Dyskinetic cerebral palsy. So this is about the brain injury. Let's move to the next question. We have a preterm baby again. Of 32 weeks gestation with a birth weight of 1300 grams. The baby develops shock after delivery, right? And due to excessive blood loss. Due to excessive blood loss, this child has shock. IV access is secured. Now they're not asking the management of shock. They're asking just the 24-hour fluid requirement for this preterm baby. So day 1 का ही बच्चा है, अभी हुआ है ना आफ्टर डिलीवरी. day 1 पे पूछ रहे हैं कि इस प्रीटर्म बच्चे की जिसका वेट 1300 ग्राम्स है, इसकी 24-hour रिक्वायरमेंट कितनी होगी. सो क्या है? 60 ml per kg, 80 ml per kg, 100 ml per kg और 40 ml per kg. Brajesh is saying B. Shubham is saying A. So let us revise. What is the correct answer? The correct answer here is 80 ml per kg. How? 80 ml per kg. B is the correct answer, not A. Right? How? Look at this. This is given in your Ghai textbook of pediatrics. This is also given in your AIMS NICU protocol. Right? So depending upon the weight of the baby or depending broadly or overall on the maturity, हम start करते हैं 80 से when the birth weight is less than 1500 grams, right? 1.5 किलो से कम बच्चा, 1.5 kg से less बच्चा, you start with 80 ml per kg per day and gradually you increase. Day 7 पे we have to reach 150 ml per kg, right? So for less than 1500 grams you start with 80, then increase to 95, 110, 120, 130, 140 and then finally 150. After that, after 1500 grams, you start with 60, 60, 75, 90, 120, 130, 135, 150, right? So this is about your correct 24 hours requirement. So the correct answer is option B, 80 ml per kg. Brajesh, glad you are a nursing officer attending this class. I hope this helps you. Okay, so now let's move to the next question. Which of the following statements are true regarding non-shivering thermogenesis? It is due to the presence of brown fat. True, non-shivering thermogenesis is due to brown fat. Brown fat does not have sympathetic innervation. This is false. Brown fat does have sympathetic innervation. Axilla, nape of neck, interscapular areas, they are rich in brown fat. This is definitely correct. Release of norepinephrine uncouples the beta oxidation. True. So 1, 3 and 4 are correct. Option C is correct. Right? So now let's just revise, have a broad overview about this brown fat, white fat concept. So all the babies, infants, right? They have brown fat at the time of birth and that helps in generating heat without shivering. This is known as non-shivering thermogenesis. ऐसा कैसे होता है? देखो जो brown fat है, नाम में ये brown, how, why it is brown? Because it has more number of mitochondria, and the lipid vacuoles are less. And whenever there is hypothermia or stressful situations, the sympathetic innervation to this fat would release catecholamines like epinephrine, norepinephrine, and they cause uncoupling of oxidative phosphorylation और सीधा फिर heat generate होती है. On the other hand, the normal white fat, it has less mitochondria, more lipid vacuoles. तो यहाँ पर अनकपलिंग नहीं होती, नॉर्मल फैटी एसिड ऑक्सीडेशन से आपका एटीपी जनरेट होता है, right? So the correct answer here was C, 1, 2, 1, 3 and 4. Okay, so a milestone question finally. So this question is asking at what age does this child show this feature? क्या कर रहा है बच्चा ये? Looking into the mirror and smiling, playing. So this is mirror play, right? This is mirror play. So when does this mirror play come? 2 months, 3 months, 6 months, 9 months. Can you tell me? At what age does this milestone of mirror play comes? Yes, everyone here is right. It's option C, 6 months. Right? So remember, at 6 months, child will look into the mirror and say, I am so sexy. S for sexy, S for sex, right? So 6 months, the child has this mirror play. Moving to the next question. Again, milestone question. So they have asked us to pick up the correct statement. First statement is a child can put on shoes or socks and can undress completely at 18 months. Second is a child can understand simple questions like where is your ball at 1 year. Third is a child has a vocabulary of 8 to 10 words at 2.5 years. And lastly, binocular vision is established by 6 weeks. So let's go one by one. First milestone they are asking is dressing, undressing, right? So remember, जब dressing skills की बात होती है ना, तो what is easy, dressing or undressing? Undressing is easy. पहले बच्चा undress करना सीखेगा, फिर dress करना सीखेगा, right? पहले with help करेगा, then without help करेगा. So firstly comes undressing with help at 2 years, then comes dressing with help at 3 years, and then undress and dress without help at 5 years, right? So 2, 3, 5, remember, undressing with help, dressing with help, and undressing, dressing without help at 5 years. Dressing and undressing may be the most intricate function fine motor is buttoning and unbuttoning. So unbuttoning comes at 3 years, buttoning comes at 4 years. So here the question statement was that the child can undress completely at 18 months. So this is definitely wrong, right? In fact, a child can undress with help, that also at 2 years of age. So the wrong statement. This is wrong. Then comes the language. A child can understand a simple question like where is your ball by 1 year? True, the child can answer this. Then vocabulary of a child. So if you look at the language milestone, then you can look that 8 to 10 words vocabulary comes at 18 months, right? And they are asking 2.5 years, which is actually very far. So this is wrong. Correct answer here is 18 months. Then we have binocular vision. So binocular vision, remember, is well established by 4 months of age, not 6 weeks. 6 weeks पे तो आनी शुरू होती है. It begins. Well established is by 4 months. So out of all the 4 statements, only one statement is correct, that is 2. So the correct answer here is C, only second statement, right? Moving to the next question. All other advantages of delayed cord clamping except lesser anemia, lower blood pressure, lesser IVH, lesser chances of shock. So what do you think is the correct answer over here? Chances of delayed cord clamping. So what is delayed cord clamping? So when the baby is born, if the baby does not require any form of resuscitation, we do not immediately clamp the cord and cut it, right? We wait for some time. For how long? Remember, the new guidelines say for at least 60 seconds you have to delay this cord clamping. What are the advantages of doing this delayed cord clamping? First, improved hematological status. Second, better iron stores. Then reduced clinical anemia at 2 to 6 months of age and reduced chances of IVH, and it also decreases the chances of neonatal shock, right? So if you look closely, Lesser anemia, yes, in future. Lesser IVH, lesser shock. Lower blood pressure is something which is wrong statement over here, right? We want an improved hematological status. Delayed cord clamping से lower blood pressure थोड़ी होगा, right? So B is the incorrect one. So all other the advantages, अगर यहाँ लिखा होता improved blood pressure or normal blood pressure improved status, then it would have been a correct answer. But lower blood pressure थोड़ी कराता delayed cord clamping. So B is the incorrect one. Moving to the next question, at a child draws this figure, this is a triangle, at what age does the child draw it? 3 years, 5 years, 6 years, 7 years. So triangle, when does it come? Yes, it's 5 years. So scribbling एक बार देख लेते हैं milestone. सबसे पहले pincer grasp कब आता है? 9 months पे. That is an immature pincer grasp. Mature one comes at 12 months of age. After that, the child will hold a pencil and draw a lot of things. Firstly, scribbling at 15 months. Then a child will draw a line of 2 points at 2 years of age. Then a circle at 3 years. Plus or cross sign at 4 years of age, rectangle at 4.5, triangle at 5 years, diamond at 6 years, a cylinder at 9 years, and cube at 11 years. So they were asking us triangle, right? So triangle is at 5 years of age. Moving to the next question, they are giving us Scammon curves or human growth curves, right? So we have 4 curves with us and they are asking which of these represent the lymphoid growth. What do you think is the correct answer over here? A, B, C or D? Which one represents the lymphoid growth? Yes. Yes, the lymphoid growth is C. Everyone here is right. Harish, Amit, Divyank, everyone, right? So let us revise these Scammon curves first. So curve 1, what can you notice over here? Rapid growth, most rapid growth, almost 90% of the growth in the initial 2 years of life, thereafter little to no growth. This is neural growth or brain growth, right? Neural growth or brain growth. Then look at the second one, sigmoid shape, initially rapid, then plateau, then again rapid. What is this? S-shaped or sigmoid shape. This represents your somatic growth. Then you have the third one where there is a peak in between 4 to 8 years of age. This is for lymphoid growth. And lastly, you can notice over here a spike at the time of puberty. This is sexual growth, right? So this is about the Scammon curves, the human growth curves. Okay, so now let's move to the next question. Okay, so which of the following is true about Caput succedaneum? When we talk about the head swelling in neonates, Caput succedaneum is a very common swelling, right? क्यों होती है? क्योंकि जब बच्चा एक नैरो वजाइनल कैनाल से अगर ऑब्स्ट्रक्टेड लेबर है या प्रोलॉन्ग लेबर है तो उसकी वजह से बच्चे का हेड स्टक रह सकता है इन द वजाइनल कैनाल फॉर अ लॉन्ग टाइम एंड देयर इज सबक्यूटेनियस एडिमा, right? ये obviously a transient condition है. It would be maximum in the size at the time of birth, but slowly it will go down, right? It will be a diffuse superficial swelling, would cross the suture lines और कोई complications नहीं है further, right? So size is maximum at birth, true. Resolves completely in 2 to 3 days, true. Can cross suture lines, true. All of the above. Everyone over here is right. The answer is all of the above. Let's revise the differences between Caput, Succedaneum and Cephalohematoma. So Caput we have discussed, it is a diffuse superficial swelling due to prolonged or obstructed vaginal delivery. There is essentially edema fluid over here in this swelling. It would be maximum in size at birth or soon after birth, and it disappears by 2 to 3 days of life. No complication is there. Compare it to the swelling where you have complications, that is cephalohematoma. So in cephalohematoma, what will happen? Due to instrumental delivery, due to injury at the time of delivery, what can happen? There can be bleed, right? Bleed and hematoma formation. So this is a localized deep swelling that do not cross the suture line. This bleed would be limited by the sutures line, right? And the content of the swelling is blood. it won't appear at the time of birth or soon after birth. It will take some time to increase in size. So after 24 hours of life, it will be appreciable, and it can take weeks to disappear. So by 2 to 3 weeks, it will disappear. Complication here, definitely, because bleed is there, hemolysis would be there, and there will be pathological jaundice, right? So these are the two swelling. ब्रजेश डेली क्लास तो नहीं होती है, बट बहुत फ्रीक्वेंटली क्लासेस होती हैं सारे ही 19 सब्जेक्ट्स की. आप चैनल को फॉलो कर सकते हो, हम पोस्ट डालते रहते हैं. Okay, so now let's move to the next question. A baby of 40 weeks, 2 kg, is born with meconium stained liquor. The baby did not cry at birth and was shifted to NICU, intubated. The treating doctor diagnosed perinatal severe birth asphyxia with hypoxic ischemic encephalopathy. Which of the following is not an essential criteria for defining perinatal asphyxia? Right? तो एग्जामिनर यहाँ पे हमसे क्या पूछना चाह रहा है? हमसे डेफिनेशन या क्राइटेरिया पूछना चाह रहा है पेरिनेटल एस्फिक्सिया का. राइट, तो पेरिनेटल एस्फिक्सिया समझते हैं. सो बर्थ एस्फिक्सिया क्या है? एसेंशियली that the baby did not cry after birth. क्यों important है the first cry of the baby? Why the first cry of the baby is important? Because that very first cry will give oxygen to the entire body of the baby. So if baby did not cry after birth, क्या होगा? There will be hypoxia all over the body. This is perinatal asphyxia. तो इसकी बहुत सारी definition है. The very first and the simplest definition was given by WHO. Right? That is, it is simple. Failure of initiation of breathing, that the baby did not initiate the breath, baby ने सांस नहीं लिया, या फिर sustain नहीं कर पाया breathing, right? So failure of initiation of breathing or sustaining respiration, WHO definition. But this is a very simple definition. So came NNPD. NNPD, what is NNPD? It is National Neonatal Perinatal Database. So NNPD said कि ये तो बहुत easy definition. This is a easy definition. Let's give a trickier one to the medicos, right? So they gave two definitions. One of moderate asphyxia, second of severe asphyxia. So what is moderate asphyxia? This is Apgar score 4 to 6 at 1 minute of life, or if the breathing is very slow or gasping breathing, तो moderate asphyxia बोलेंगे. Then we have severe asphyxia. If the Apgar score is less than 4 at 1 minute or the child is not breathing, this is severe asphyxia, right? So NNPT gave this definition on the basis of Apgar score and the breathing pattern. Apgar score 4 to 6 at 1 minute, moderate. Apgar score less than 4 at 1 minute, severe asphyxia, right? Then came this AAP. What is AAP? Not Aam Aadmi Party. This is American Academy of Pediatrics, right? So American Academy of Pediatrics say, I will give even tougher definition. I will take the pathogenesis and make a definition out of it, right? So what is essentially happening in perinatal asphyxia? That the baby did not cry after birth. There is hypoxia. So whenever there is hypoxia, what will happen? My body will do anaerobic respiration, anaerobic metabolism. And we all know the byproduct of anaerobic metabolism is lactic acidosis. So there will be acidosis, metabolic acidosis in the body of the baby. Also, because there is hypoxia, there will be damage to different structures. And the most important structure, most important organ we have is brain. So there will be brain injury, hypoxic ischemic encephalopathy. Apart from that, other organs like kidney, gut, all of these would also be affected. Most commonly, kidney is affected. So AAP took this pathogenesis and made a definition out of it. Firstly, I know what is going to happen. Acidosis is going to happen. So the first point in the criteria of perinatal asphyxia is acidosis. So you see profound acidemia, that is pH less than 7 in the umbilical cord blood. Second criteria is on the basis of Apgar score, but remember here we are taking Apgar score at 5 minutes, not 1 minute, right? So the Apgar score is less than 4 or 0 to 3 at 5 minutes. Then third criteria is this brain problem. So if you have evidence of CNS dysfunction, another criteria for perinatal asphyxia. And then the last, I need multi-organ problem. So there should be evidence of multi-organ dysfunction. So this is the 4 criteria of perinatal asphyxia. Profound acidemia, that is pH less than 7 in the umbilical cord blood. Apgar score 0 to 3 at 5 minutes. Evidence of CNS dysfunction. Evidence of multi-organ dysfunction. Right? So now let's go back to the question. They were asking which of these is not a criteria. So the first criteria says presence of Apgar score of 5 to 7 for more than 5 minutes. This is not a criteria, right? I know the criteria says Apgar score 0 to 3 or less than 4 at 5 minutes. So this is wrong. Prolonged umbilical arterial blood pH less than 7. This is correct. Profound acidemia. Evidence of neurological manifestations. True. CNS dysfunction. Evidence of multi-organ dysfunction. Again true. So what is the incorrect answer? What is the incorrect option first? Right? So this is not an essential criteria. Option A. All of you are correct. It's option A. Moving to the next question. Which of the following is the most important indicator of successful resuscitation? I don't know how many times they have asked in this question in the exam. A lot of times they have repeated the same question. Remember, the most important indicator when you are resuscitating a child is increase in heart rate. Increase in heart rate, right? So increase in the heart rate, remember, is the most important indicator of successful neonatal resuscitation. Option B, right? Moving to the next question, a child was admitted in the pediatrics department with asymmetric Moro's reflex, which does not cause this asymmetry. Options we have are Erb's palsy, clavicle fracture, Down syndrome, or shoulder joint dislocation. So Moro's reflex हम सब समझते हैं. If you do a sudden extension of the head of the baby, what will happen? Embrace reflex, जैसे Moro's reflex होगा, है ना? There is extension, adduction, flexion, and sometimes the fifth component cry is also there. So the question here is asking that there is asymmetric Moro's reflex, matlab only one side this is happening, the other side is not moving. In which all situation this can happen? Obviously, if there is Erb's palsy on one side, that limb won't be moving, so you will see asymmetry. If there is clavicle fracture on one side won't be moving, again true. If there is shoulder joint dislocation, again there will be asymmetry. So in which cases there will not be asymmetry? In Down syndrome, there is no reason for asymmetry in Down syndrome, right? So now let's revise the abnormal Moro's pattern. First, absent Moro's, when you are not going to appreciate Moro's reflex. HI3, obviously there is brain injury, you cannot elicit this reflex. There is some cortical malformation. Asymmetric Moro's reflex in neurological conditions like Erb's palsy, brachial plexus injury, skeleton problems like clavicular flexion, shoulder dislocation. Persistent Moro's, that means the Moro reflex is not going, reflexes are persisting. This will happen in cases of cerebral palsy. And then exaggerated Moro's. Exaggerated Moro's you see in hypoglycemia and HI stage 1. Right? So remember the Moro's reflex, very important reflex, and the abnormalities are also again very important. So moving to the next question, I have a mother with us. Because of her hectic schedule, she was unable to adequately feed her infant. She requested the doctor to provide an alternative feed. Basically, she is asking the doctor that can she give formula milk or some other type of milk to the baby. The doctor informed her about the express breast milk technique. How long can EBM be stored at room temperature? 6 hours, 12 hours, 24 hours, 36 hours. So what is the correct answer over here? Yes, it's A, 6 hours, right? So mothers can actually express their breast milk and store it, and then someone else can feed it if mother is not available, right? So how can we store this express milk? You can store it at room temperature. If stored at room temperature, it can stay good till 6 to 8 hours. In refrigerator, around 2 to 8 degrees Celsius up to 24 hours, and in special freezers, deep freezers, up to 3 months, right? So this is how we store express breast milk. Moving to the next question, which of the following are the criteria for diagnosing SAM, that is severe acute malnutrition? Weight for height below -3 standard deviation, height for age below -3 standard deviation, bipedal edema, and mid upper arm circumference less than 115 mm. So what is the correct answer over here? This is correct, this is correct, this is correct, right? So A is correct, C is correct, and D is correct. Option C is the correct answer. So let us revise the criteria for SAM. Severe acute malnutrition. Any one out of these if present, this is SAM. First is weight for height less than -3 standard deviation. That means there will be visible severe wasting. right? There will be severe wasting. Then you have mid-upper arm circumference. Obviously, this is for the babies 6 months to 5 years of age. If MUAC is less than 11.5 centimeters, this is the criteria. And last, you have bilateral edema, nutritional edema, right? So this height for age is not a criteria. So the correct answer here is C. Moving to the next question. A mother brought her 4-year-old male child with complaints of frequent diarrhea, difficulty breathing, lack of appetite, and weight loss. On evaluation, the child was diagnosed with SAM. Which of the following is not a medical complication? Hypoglycemia, hyperthermia, infection, dehydration. Remember, a SAM child will not have a problem of hyperthermia. They will have hypothermia. In SAM, you do not see the classical signs of infection, right? Hyperthermia. If you get an infection, you will develop a fever. But here, you won't get that. You will have hypothermia. In fact, there is a triad of hypothermia, hypoglycemia, infections, right? So B is the correct answer over here. Yes, true. Moving to the next question, in the image given below, this child had complaints of frequent diarrhea, abdominal swelling, delayed growth and development. What is not true about the disease? What can you interpret about this picture? What can you see? Can you see the pot belly over here? Right? So this is nothing but a very malnourished child with one of the severe forms of malnutrition, that is Kwashiorkor. So let us read the statement one by one. Usually seen in a child aged 1 to 4 years of age. True. We usually see this post 1 year of age when the diet is very, the feed of the child, the diet of the child is replaced by a very low protein diet. So yes, this is correct. Baggy pant appearance is seen? No. Baggy pant is more appreciable in marasmus child rather than Kwashiorkor. Kwashiorkor babies can swell up and look like a fat sugar baby. C is crazy pavement dermatosis is seen. True, we see hair and nail changes, hair and skin changes, and crazy pavement dermatosis is one of them. Lastly, we have child may look like a fat sugar baby. Again, true, due to edema, the child can look like a fat sugar baby. So, not true would be option B, right? All of you are right, option B. Moving to the next question, mark the correct answers regarding the characteristics of the disease. So we have certain diseases and their characteristic features we have to match. So let's go one by one. Osteomalacia. What is the reason of osteomalacia? Vitamin D deficiency in grown bones. That means delayed mineralization. 1B. Then we have scurvy. What do you see in scurvy? We see Wimberger's ring. Then you have rickets. We see cupping. Then you have osteoporosis, increased radiolucency. So 1B, 2A. Option C is the correct answer over here. Right? Moving to the next question, a 8-year-old boy presented with painful joint swelling, delayed dentition and delayed wound healing. X-ray shows the findings below. What is the probable diagnosis? Just अभी हमने देखा scurvy में क्या दिखता है हमें? Wimberger's ring, right? So you can see the epiphysis ring. This is the Wimberger ring. So in this you see a Wimberger ring sign that is characteristic of scurvy. Right, scurvy में और क्या क्या दिखता है हमें? Wimberger's ring. We have this white line of Frankel. Below that we have Trommelfeld zone. We have Pelton spur, and the cortex is very thin. This is pencil thin cortex, and you can also appreciate subperiosteal bleeds. Okay, so this is about scurvy. A 3-year-old presents with intermittent colicky, abdominal pain, vomiting, and passage of current jelly stool, right? This current jelly stool is buzzword. So what is this? Current jelly stool, colicky pain, vomiting, this is intussusception. Whenever you have this current jelly stool, this is a buzzword for intussusception. Option B. Moving to the next question. We have a 2-year-old girl who is brought to the clinic with high-grade fever. There is cough, red eyes, and a rash. So we have a child with fever, rash. So fever with rash. Fever with rash is a very important topic for FMGE exam. On further investigation, it was found that the rash started on the forehead behind the ears and then subsequently spread it to the neck and the body, forming a confluent maculopapular rash as shown in the image below. Right, so this is the image they have given. They said that this rash, this maculopapular rash, started behind the ear, then to the face, neck, and trunk. Which of the following is false regarding the condition? First of all, what is this typical distribution of the rash? This is typical for measles, right? So this is a measles rash, maculopapular rash that starts behind the ears, then to the face, then to the trunk. And usually when this rash goes, it leaves behind hyperpigmentation. So this is measles. So they are asking which of the following statements is false regarding measles. So the first statement is the period of infectivity is 2 days before and 7 days after the appearance of rash. This the first statement only is false, right? So हमें पता है rash के onset से 4 days पहले, 4 days before the onset of rash and 4 days after the onset of rash, or you can say rash को अगर आप include करोगे तो 5 days, right? So this is the infectivity period, not 2 days before and 7 days after. So first statement is false. Option B, diagnosis is confirmed by estimating levels of IgM, anti-measles antibody, true. Then you see this Worth and Finkelty giant cells, true. Koplik spots are pathognomic, true. Right? So the incorrect option was A. A. 4, 5, right. With that, now let's revise these conditions, fever with rash. So I've made a table so that we can easily revise all of these. So firstly, measles, also known as rubiola. We all know what is the cause of measles, RNA paramyxovirus. What will be the presentation? Firstly, you will have a prodrome, viral prodrome, 3 C's, cough, coryza, conjunctivitis. Koplik spots in the buccal mucosa, pathognomic. And what is the typical rash? Descending pattern. It will start at the hairline or behind the ears and then spread to trunk and limbs over the next 3-4 days. Complications में most common complications of measles is otitis media. Most common cause of death is pneumonia, and late neurological sequelae is SSP. Then second disease we have is rubella. Cause is RNA toga virus. यहाँ pathognomic is for Scheimer spots. These are soft petechiae over the soft palate. And also you appreciate lymphadenopathy. Here the rash is again maculopapular rash, but it resolves rapidly, right? It is also known as 3 days measles. And also it won't leave behind the hyperpigmentation as the measles rash do. Usually it is mild in cases of children, but because highly teratogenic congenital rubella syndrome हो सकता है, इसलिए we vaccinate with rubella vaccine. Then you have varicella. We all know the cause of varicella. It's varicella zoster virus. The typical pathognomic here would be dewdrops on rose petal appearance, right? Vesicles, छोटे-छोटे vesicles दिखेंगे and the base is red, so it is known as dewdrops on a rose petal appearance. And pathognomic here would be pleomorphic appearance, मतलब different stages of lesions present simultaneously over the skin. Distribution classically centripetal, that means more of these vesicles would be over the trunk and less over the limbs. And the complication here is secondary bacterial skin infection by Staph aureus pyrogens. And here remember, avoid aspirin because it can lead to Reye syndrome. Lastly, we have scarlet fever caused by group Tase streptococcus as a result of erythrogenic exotoxin. You will notice strawberry tongue. And the typical rash here is sandpaper textured rash. It starts in the groin or the axilla and then spread to the trunk. Remember, its pale is the perioral region, so there will be circumoral pallor. Complication is rheumatic fever, PSGN. Treatment is penicillin or amox. Right? So this is about fever with the rash. Moving to the next question, a follow-up question only. Mark the correct answer regarding the characteristic features of the following disease. Koplik spots. Koplik spots, I told you, is the characteristic feature of measles, which is also known as rubiola. So Koplik spots, B. Then you have for Scheimer spots, it's for rubella. Slab-cheeked appearance, erythema infectiosum. Nodular rash, molluscum, right? So 1 is B, 2 is D. Slab-cheeked appearance, you see in A. So the correct answer here is C, right? Option C. Moving to the next question. A child presents with acute onset of high fever, inspiratory stridor, drooling of saliva, tripod posture. What is the most appropriate immediate management step? Perform a thorough throat examination using a tongue depressor, administer nebulized salbutamol, secure the airway in controlled setting, or start oral antibiotics immediately. What do you think is the correct answer? What is this classical picture? High fever, stridor, drooling of saliva, tripod posture. Yes, this is nothing but acute epiglottitis. And acute epiglottitis is a very emergency condition. You start with airway breathing circulation, right? So the correct answer here is C. So let us revise. Acute epiglottitis, age group is 1 to 3 years of age. The cause here is bacteria H influenza type B. This child will present with high grade fever, very toxic looking, muffled voice, drooling of saliva, severe distress, a typical tripod posture. Can you look at this child? This child is leaning forward with both of his hands, tripod posture. And on X-ray, you see a thumb sign, which is basically swollen up epiglottis. Here, the management includes stabilization, ABC, and then antibiotics. And these antibiotics are not oral antibiotics. The child is very sick. You do not give oral antibiotics. You give IV antibiotics, right? So this is about acute epiglottitis. Now let's move to the next question. We have a 4-year-old boy who presents with progressive proximal muscle weakness, calf pseudohypertrophy, and difficulty from rising from the floor. Serum CPK levels are also elevated. What is the diagnosis? देखो कितना classical picture है ना? Less than 5-year-old child, proximal weakness, calf pseudohypertrophy, difficulty in rising from the floor, that is the go-over sign. CPK is also elevated. This is nothing but Duchenne muscular dystrophy, right? Beckers तो आफ्टर 5 years प्रेजेंट करेगा और ऐसे सिवियर फीचर्स नहीं होंगे. माइस्थीनिया ग्राविस अगेन कैसी पिक्चर होगी माइस्थीनिया ग्राविस में? देयर विल बी डायगोनल वेरिएशन, एसिमेट्रिकल फेस इन्वॉल्वमेंट. स्पाइनल मस्कुलर एट्रोफी अगेन it won't present like this in a 4-year-old with proximal. It will present early on. So the correct answer here is Duchenne muscular dystrophy. You all know what is the inheritance of Duchenne muscular dystrophy? X-linked recessive. That means it will be seen in males. The problem here is in the X chromosome, short arm XP21, that codes for dystrophin protein. अगर म्यूटेशन नॉनसेंस प्रोटीन है, फ्रेम शिफ्ट नॉनसेंस म्यूटेशन है, फ्रेम शिफ्ट म्यूटेशन है, देयर विल बी नो प्रोटीन, dystrophin protein, and we have DMD with us. If there is missense mutation, we have some protein. This we have Becker's then. We have proximal muscle weakness, onset before the 5 years of age, and because of this proximal muscle weakness, waddling gait, calf pseudohypertrophy, Gover signs, scoliosis of the spine. Investigation may you will see risen CPK, and the best is molecular testing. Moving to the next question. Which statement is incorrect regarding pneumonias? So the first statement is important cause of under 5 mortality. True, pneumonia is a very important cause of under 5 mortality. Viruses are more common than bacteria. Remember when we talk about pneumonia in children, bacterial pneumonias are more common as compared to viral. But when I talk about diarrheas, then viral diarrheas are more common as compared to bacterial, right? So the statement that viral diarrhea are more common than the bacterial diarrhea is false. Pneumonia is the consolidation of alveoli or infiltration of the interstitial tissue, again correct. And lastly we have RSV is the most common virus that causes the pneumonia, again true, right? So the incorrect statement is option B. Moving to the next question, arrange the following in the ascending order of oxygen saturation in the fetal blood vessels. So you have the fetal circulation structures and you have to tell ascending order of saturation. मतलब सबसे low and then सबसे high. So start करते हैं. कैसे start होता है हमारा fetal circulation? What is the source of oxygen for the fetus? Yes, source of oxygen. Source of oxygen is placenta. Placenta से आती है आपकी umbilical vein. So umbilical vein carries the oxygenated blood. Umbilical vein, abhi oxygenated blood has to travel the entire body of the fetus. So it has to reach heart. For that it joins another vein, that is inferior vena cava. through a duct. This is a duct joining two veins. So this is known as ductus venosus. Now this IVC will go to the heart. We have the right side, we have the left side. So firstly, it will reach the right atrium, but the circulation has to happen through the left side. So some of the blood will go to the left side, right? Rest will go down into the right ventricle and then to the pulmonary artery. But because the pulmonary circulation vascular resistance is high, this oxygenated blood will be shunted to the left side through a duct. So this is again a duct joining the two arteries, pulmonary artery and the aorta. This is known as ductus arteriosus. This structure is foramen ovale. Right? So they are asking the order of saturation, right? So firstly, highest कहाँ पे होगा? Highest umbilical vein. Highest होगा umbilical vein. Umbilical vein will be the highest, right? उसके बाद आएगा हमारा डक्टस वेनोसस, फिर आएगा आईवीसी, फिर आएगा आपका राइट साइड, फिर आएगा आपका आगे फर्दर वेसल्स. सो मूव करते हैं. सबसे ज्यादा कहाँ पर है? सबसे ज्यादा इज इन योर umbilical vein. Maximum is in the umbilical vein, but यहाँ दिख रहा है umbilical vein. Then you have duct, IVC. Then finally ascending aorta, descending aorta, and then umbilical arteries. Right? So option B is correct. Got it? Option B is correct. Moving to the next question. We have a 2-month-old infant who is brought to the clinic with fast breathing, poor feeding, and failure to thrive. Infant was asymptomatic at birth, but on examination, you notice a loud, harsh, hollow systolic murmur heard in the left lower sternal border with a palpable thrill. What is the most likely diagnosis? Right? Straightforward, कितने सारे clues हैं. A child with pneumonia-like picture, failure to thrive, or holosystolic murmur सुनाई दे रहा है. What is this? This is nothing but ventricular septal defect. B. Right? ASD में तो ऐसे symptoms होंगे ही नहीं. Usually asymptomatic होता है या mildly asymptomatic होता है. Right? PDA में आपको machinery murmur दिखेगा. So the correct answer here is ventricular septal defect. Moving to the next question. During neonatal resuscitation, a newborn has a heart rate of 50 after 30 seconds of effective positive pressure ventilation. What is the immediate next step? Continue ventilation, start chest compressions, administer epinephrine, or provide oxygen by a hood. What do you think is the correct answer over here? 30 seconds हो गए effective positive pressure ventilation की, the heart rate still is 50. So what is the correct answer? What should you do next? We do chest compressions. Right? You start chest compressions with ventilation. So what is the core of NRP? Effective ventilation is the core of NRP. So even after 30 seconds of effective positive pressure ventilation, if the heart rate is still less than 60, we start with chest compressions. Right? So start करते हैं. जैसे ही बच्चा होगा, we ask 3 questions, that is term, tone, and cry. If the baby is term, is the baby's tone good? Did the baby cry? If the answer to any of these questions is no, you go for initial steps of resuscitation. Initial steps of resuscitation. What are the initial steps? Position, airway, dry, stimulate. Position, airway, dry, stimulate. After initial steps of resuscitation, if the heart rate is less than 100, then you start with positive pressure ventilation, and this should be started within 1 minute. This is known as the golden 1 minute. After 30 seconds of effective positive pressure ventilation, if the heart rate is still less than 60, Then you start with chest compressions along with ventilation, right? After 1 minute of this, that is 60 seconds of this, if the heart rate is still less than 60, then you give epinephrine. And despite giving 3 to 5 doses of epinephrine, if the child is not improving, think of two things. First, pneumothorax. Check the breath sounds. If there is pneumothorax, do needle thoracotomy. Right? And the second could be blood loss. So if you think the baby is in shock, blood loss, then you do volume expansion. Volume expansion by giving IV fluids. So this is the core algorithm of NRP. So here they were saying that after effective positive pressure ventilation, heart rate is still less than 60, 50 here. So we have to start chest compressions with ventilations, option B. Moving to the next question, a 4-year-old child presents with high fever, barking cough, hoarseness, and inspiratory stridor that worsens at night. What is the most likely diagnosis? बहुत simple सा है ना, high fever है, barking cough है या brassy cough है, stridor is there, worsening at night. This is classical picture of group laryngotracheobronchitis group, right? एपिग्लोटाइटिस तो अभी हमने देखा था सिनेरियो, वेरी टॉक्सिक लुकिंग बच्चा. फॉरेन बॉडी एस्पिरेशन डेफिनेटली वुड हैव सडन ऑनसेट कॉफ और रेस्पिरेटरी डिस्ट्रेस. ब्रोंकियोलाइटिस में ऐसे बार्किंग कफ तो नहीं दिखेगा आपको, स्ट्राइडर भी ऐसे नहीं दिखेगा, राइट? यू मोर विल अप्रिशिएट these. So the correct answer here would be group B, steeple sign. Yes, correct. Moving to the next question, a 7-year-old girl, she frequently stops speaking mid-sentence, shows a blank stare, fluttering of eyelids for about 10 seconds before resuming the normal activity. These episodes are triggered by hyperventilation. Which EEG pattern is the most characteristic of this disorder? 3 spike and wave complex, hypsarrhythmia, 2.5 hertz or 4 to 6 hertz. What do you think is the correct answer over here? What is this condition? देखो typical दे रखा है, school going child और brief vacant staring looks हैं, triggering by hyperventilation. This is nothing but absence seizure, right? So this is nothing but absence seizure. And what is the EEG pattern that you see in absence seizure? It is 3 hertz spike and wave complex, right? 3 hertz spike and wave complex. कैसा दिखता है spike and wave complex? ऐसे spike and then wave, spike and then wave. तो ऐसे 1 second में आपको 3 spikes and wave दिखेंगी. This is classical of your absence seizure. हिप्सरिथमिया कहाँ दिखता है? हिप्सरिथमिया क्या होता है? हाई वोल्टेज बहुत क्योटिक पैटर्न, ऐसे जैसे किसी ने स्क्रिबल कर दिया, क्योटिक पैटर्न, हाई वोल्टेज. ये कहाँ दिखता है? दिस इज क्लासिकल ऑफ वेस्ट सिंड्रोम. Then you have 4 to 6. ये कहाँ दिखता है? 4 to 6 hertz. This you see in juvenile myoclonic epilepsy. Right? And 1 to 2 hertz. You see in Lennox-Gastaut syndrome. Right? So this is about the EEG patterns. Now let's move to the next question. We have a 7-year-old boy with short stature. His height is below 3rd percentile. The growth velocity is normal. Bone age is delayed compared to the chronological age. There is a family history also of delayed puberty in the father. What is the most likely diagnosis? Familial short stature, constitutional growth delay, growth hormone deficiency और hypothyroidism. देखो सबसे पहले यहाँ दे रखा है कि growth velocity normal है for the age. तो ये पक्का pathological short stature तो नहीं है. This is physiological short stature. And in physiological short stature, you have two entities. We have familial short stature and constitutional delay in growth and puberty. Familial short stature में तो parents भी short होंगे, right? But constitutional delay in growth and puberty में parents are normal heighted and they have a history of delayed puberty. और यहाँ पे भी दे रखा है delayed puberty and also bone age is also delayed as compared to chronological age. Familial short stature में तो bone age is equal to the chronological age. So the correct answer here is B. Akhilesh is right, Shubham is right. Okay, so moving to the next question, we have a 9-month-old who presents with clusters of flexor spasm, developmental regression. EEG also has hypsarrhythmia. What is the most likely diagnosis over here? Febrile seizure, West syndrome, LGS, और बिनाइन मायोक्लोनिक एपिलेप्सी। अभी हमने डिस्कस किया था हिप्स अरिथमिया कहाँ दिखता है, वेस्ट सिंड्रोम में दिखता है, राइट। सो वेस्ट सिंड्रोम में ट्रायड आपको ध्यान रखना है। ट्रायड क्या है, एक सीजर फाइंडिंग है, एक डेवलपमेंटल फाइंडिंग है, एक ईईजी फाइंडिंग है। क्या सीजर है, हमें दिखता है यहाँ पे स्पैसम, इन्फेंटाइल स्पैसम, राइट, जिसे सलाम स्वेल भी बोलते हैं। Then we have developmental finding, developmental regression. That means loss of previously attained milestone. अगर पहले बच्चा बैठ पा रहा था, the child was sitting earlier, now the child won't be able to sit. There is developmental regression. And third is the EEG picture, that is hips arrhythmia. You see high voltage chaotic pattern, right? So EEG pattern अगर आप देखोगे वो high voltage ऐसे chaotic सा pattern होगा, right? So the correct answer here is B. Moving to the next question, a 4-month-old had an inspiratory stridor since birth but no fever. The stridor in the chest retractions, they become prominent in the supine position and disappear in the prone position. देखो सब कुछ ही बता दिया उन्होंने, है ना। मोस्ट प्रोबेबल डायग्नोसिस आप पूछ रहे हैं, फॉरेन बॉडी एस्पिरेशन, क्रूप, एक्यूट एपिग्लोटाइटिस, लैरिंजोमलेशिया, राइट। सो सबसे पहले एक्यूट एपिग्लोटाइटिस को तो हटा दो, बहुत टॉक्सिक चाइल्ड होगा ये, है ना। फीवर होगा, बहुत हाई ग्रेड सिम्टम्स होंगे इसको, तो ये रिमूव कर दिया। फॉरेन बॉडी एस्पिरेशन सिंस बर्थ नहीं हो सकता अगेन, राइट, और सडन ऑनसेट होगा, इतना लंबा तो चलेगा नहीं। क्रूप वाला बच्चा भी देयर विल बी बार्किंग, कॉफ, फीवर। इट इज लैरिंजोमलेशिया। लैरिंजोमलेशिया का क्लासिकल है कि प्रोन पोजिशन पे डिसअपियर हो जाता है, राइट, प्रोन पोजिशन पे डिसअपियर हो जाता है। व्हाट इज लैरिंजोमलेशिया, व्हाट हैपेंस इन लैरिंजोमलेशिया? So laryngomalacia, remember, is the most common laryngeal anomaly. यहाँ पे larynx जो है वो lax है। तो supine position में क्या होगा, जब बच्चा सीधा लेटा होगा तो epiglottis will fall, it will be pushed down, तो that will obstruct my airway and cause stridor. जब इसको prone position में कर लेंगे that would disappear, क्योंकि epiglottis अब airway से दूर हो गया। यहाँ classically laryngoscopy पे हमें दिखता है ऐसे lax larynx, omega shaped epiglottis. Nothing has to be done here, just reassurance. It usually resolved by 2 years of age. अगर बहुत severe है and distress भी बहुत severe है, then we can go for supraglottoplasty, right? So this is about laryngomalacia. Moving to the next question. We have a 1-year-old child with recurrent chest infections, failure to thrive, and bulky foul-smelling stool. And the sweat chloride test is elevated. What is this classically seen in? What is the most likely diagnosis? Bronchial asthma, cystic fibrosis, primary ciliary dyskinesia, tuberculosis, right? So sweat chloride test आपको सबको पता है, गोल्ड स्टैंडर्ड किसका है, सिस्टिक फाइब्रोसिस का है। ब्रोंकियल एस्थमा में तो बच्चा कैसा प्रेजेंट करेगा, रिकरेंट वीज के साथ प्रेजेंट करेगा। प्राइमरी सीलियरी डिस्किनेसिया में आप ये सारी चीजें तो देख सकते हो, बट ये स्वेट क्लोराइड टेस्ट नहीं होगा। टीबी की पिक्चर भी ऐसी नहीं होगी, स्वेट क्लोराइड टेस्ट यहाँ पे भी एलिवेटेड नहीं होगा। इट्स ऑप्शन बी, सिस्टिक फाइब्रोसिस। Moving to the next question, a preterm neonate presents with a continuous machinery murmur. So कहाँ दिखता है machinery murmur and bounding pulses? VSD, PDA, ASD or coarctation of aorta? Machinery murmur is classically seen in B. Yes, B. Patent ductus arteriosus. Moving to the next question. We have a 6-week-old infant who presents with progressive projectile non-bilious vomiting after the feeds. There is visible peristalsis and a palpable olive-shaped mass in the epigastrium. What is the metabolic abnormality seen? Metabolic acidosis with hyperkalemia, hypokalemic metabolic alkalosis, hypernatremic dehydration, respiratory alkalosis. तो क्या है ये? What is this condition? This is nothing but congenital hypertrophic pyloric stenosis. तो क्या होता है congenital hypertrophic pyloric stenosis में? अगर ये आप स्टमक देखो तो आपका ये पाइलोरिक एंड है जो फर्दर ड्यूडेनम से कनेक्ट करता है, तो यहाँ पे हाइपरट्रोफी हो जाती है आपकी सर्कुलर मसल्स की। सो देयर इज हाइपरट्रोफी ऑफ द सर्कुलर मसल्स एट द लेवल ऑफ पाइलोरिक एंड। सो यहाँ गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन हो जाएगी, इसलिए बच्चा जो भी खाएगा वो बाहर वॉमिट आउट करेगा। देयर विल बी प्रोजेक्टाइल वॉमिटिंग, और एक ऐसी वॉमिटिंग होगी बिलियस और नॉन बिलियस, बाइल तो नीचे ड्यूडेनम में सिक्रीट हो रहा है, सो देयर विल बी प्रोजेक्टाइल non-bilious vomiting. With vomit क्या क्या निकलेगा? There will be loss of the gastric juices, loss of H plus H plus and chloride, and also loss of your water, loss of sodium. That would stimulate my RAS. RAS में aldosterone जो है वो क्या करेगा? That will conserve my sodium and excrete H plus and K plus. राइट, सो ओवरऑल क्या पिक्चर आ रही है? देखो, लॉस ऑफ H प्लस, सो क्या होगा? मेटाबॉलिक एल्कलोसिस, एसिड चला गया ना तो एल्कलोसिस। इलेक्ट्रोलाइट्स में सोडियम तो मेरा कंजर्व हो गया, लेकिन पोटेशियम जा रहा है, क्लोराइड जा रहा है, तो देयर विल बी हाइपोक्लोरीमिया, देयर विल बी हाइपोकलीमिया, राइट। और H प्लस देखो मेरा यूरिन में भी जा रहा है, सो देयर विल बी पैराडॉक्सिकल एसिड्यूरिया, पैराडॉक्सिकल एसिड्यूरिया। सो ये मेटाबॉलिक पिक्चर दिख रही है, मेटाबॉलिक एल्कलोसिस है, हाइपोक्लोरीमिया, हाइपोकलीमिया एंड पैराडॉक्सिकल एसिड्यूरिया। तो ऑप्शंस में जाओ, ऑप्शन बी इज द करेक्ट ओवर है, राइट, हाइपोक्लोरीमिक, हाइपोकलीमिक, मेटाबॉलिक एल्कलोसिस, दिस इज द करेक्ट आंसर ओवर है, right? Moving to the next question. A preterm neonate developed respiratory distress soon after birth. Their chest X-ray shows ground glass appearance, air bronchogram. What is the underlying pathology? Right? Very simple. What is the underlying pathology? X-ray भी आपको बता रहा है ground glass, air bronchogram और preterm baby भी है. So this is nothing but RDS, right? Hyaline membrane disease or respiratory distress syndrome. क्या होता है इसमें? There is lack of mature surfactant. So the correct answer here is surfactant deficiency B. Moving to the next question. A 4-year-old presents with fever for 6 days, bilateral conjunctival congestion, strawberry tongue, polymorphous rash, cervical lymphadenopathy. What is the most serious complication if untreated? Glomerulonephritis, कोरोनरी आर्टरी एनोरिज्म, रोमैटिक हार्ट डिसीज, इन्फेक्टिव एंडोकार्डाइटिस। सबसे पहले डायग्नोसिस बताओ। फीवर देखो मोर देन 5 डेज है, बायलेटरल कंजक्टाइवल कंजेशन, स्ट्रॉबेरी टंग, रैश, lymphadenopathy. This is nothing but Kawasaki disease. And we all know the most serious complication of Kawasaki disease is coronary aneurysm. तभी हम कावासाकी डिसीज की ट्रीटमेंट में IVIG के साथ एस्पिरिन ऐड करते हैं फॉर एंटी इन्फ्लेमेटरी एक्शन। जस्ट बाय गिविंग एस्पिरिन आप डिक्रीज कर सकते हो चांसेस ऑफ दिस कोरोनरी आर्टरी एनेरिज्म फ्रॉम 25% टू लेस देन 5%, right? So the correct answer here is B, coronary artery aneurysm. Moving to the next question. A 2-year-old presents with pallor and koilonychia. Which investigation best confirms the iron deficiency? So जब भी iron deficiency की बात करते हैं आपको फटाफट stores देख रहे हैं, stores मतलब ferritin, ferritin बताता है कि कितने iron stores हैं. So what would be the correct answer over here? Iron deficiency है, so there will be low serum ferritin, low serum ferritin, right? बाकी options देखते हैं. Elevated तो नहीं होगा serum ferritin, there is iron deficiency. serum iron बढ़ा भी नहीं हुआ होगा. टोटल आयरन बायरन कैपेसिटी इंक्रीज हो जाएगी बिकॉज डेफिशिएंसी है, राइट? सो दिस इज ऑल्सो रॉन्ग. सो आयरन डेफिशिएंसी में आपको क्या पिक्चर दिखेगी? लो सीरम आयरन, लो फेरिटिन, increased total iron byron capacity, right? So the correct answer here is B. Moving to the next question. A newborn child was brought to the hospital with cyanosis immediately after the birth, and the X-ray shows a classic egg on string appearance. Where do you see this egg on string appearance? Epstein anomaly, AV septal defect, tricuspid or transposition of great vessels. So कहाँ दिखता है आपको ये egg on string appearance? We see this in transposition of great arteries, right? What do you see in Epstein anomaly? Epstein anomaly में क्या दिखता है? You see box shaped heart, right? जो frequent जो एक्सरेज हैं वो डिस्कस कर लेते हैं, right? सबसे पहले आता है हमारा boot shaped heart. boot shaped कहाँ दिखता है आपको? boot shaped heart, you see this boot shaped heart in TOF. Then we have box shaped heart, Epstein anomaly. Then you have this figure of 8 or snowman appearance. Where do you see this? You see this in supracardiac TAPVC. Right, then you have this question, egg on string appearance. You see this in TGA. Right, so important X-rays and their CHDs. Moving to the next question, a child develops severe metabolic acidosis, hyperglycemia, ketosis during an acute infection. What is this? Acidosis, hyperglycemia, ketosis. This is nothing but DKA, diabetic ketoacidosis. So they are asking which hormone is deficient and responsible for this clinical state. So हमको पता है type 1 diabetes में हम देखते हैं ये DKA वाली situation, और कौन सा हार्मोन प्रॉब्लम है यहाँ पे? इंसुलिन डेफिशिएंसी इज देयर, राइट, ए इंसुलिन. Moving to the next question, a child with known seizure disorders develops a continuous generalized tonic-clonic seizure lasting for 5 minutes. According to the status epilepticus protocol, what is the first line ड्रग ऑफ चॉइस? सो रिमेंबर, जब भी आपके पास कोई ऐसे सीजर करके बच्चा आता है, द सीजर इज लास्टिंग फॉर मोर देन 5 मिनट, सबसे पहले हम उस सीजर को अबॉर्ट करेंगे. उस सीजर को अबॉर्ट करने के लिए हम क्या देते हैं? बेंजोडाइजेपिन्स. व्हिच बेंजोडाइजेपिन्स? यू कैन गिव मिडाजोलाम, लोराज़ेपाम, डाइज़ेपाम. सो द करेक्ट आंसर हियर इज दिस इज द फर्स्ट लाइन. After that, you start another anti-epileptic. It can be phenytoin, it can be valproate, right? So the correct answer here is C, intravenous lorazepam. Moving to the next question, we have a 2-year-old with acute watery diarrhea, sunken eyes, lethargy, and a very slow skin pinch return. According to WHO guidelines, what is this degree of dehydration? No dehydration, some dehydration, or severe dehydration, or hypernatremic dehydration. देखो बहुत सारी चीज़ें दे रखी है ना, sunken eyes है, lethargic है, and very slow skin pinch. What is this? This is severe dehydration, C. Yeah. So let's revise the degrees of dehydration. We have no dehydration, some dehydration, and severe dehydration. So no dehydration में क्या होता है? यहाँ बच्चा dehydrated थोड़ी है, no dehydration is there. So this child would be alert, right? Generally alert. Eyes would look normal to you. Skin pinch would be instant recoil. Oral mucosa will be moist, right? And if you offer the water to the child, you check the thirst and offer water, ये बहुत आराम से बच्चा पिएगा, will, right? So the thirst is normal over here. What happens in some dehydration? Now some level of dehydration has started. So this child would be now irritable. Eyes look sunken. Skin pinch is slow but usually less than 2 seconds. Oral mucosa is dry and this child has a lot of thirst, right? So the child will eagerly drinks. Then we have severe dehydration. Here the child is very lethargic, comatose. Eyes would definitely be very sunken. Skin pinch is very slow, more than 2 seconds. Oral mucosa very dry, and obviously this child cannot drink, unable to drink, right? So in our question, they were giving lethargy. That itself says that this is severe dehydration. So the correct answer here is severe dehydration. Yes, you are correct. We have plans for the management of these dehydration. In no dehydration, I give plan A. Here I give plan B. Here I give plan C. What is plan A, plan B, plan C? In plan A, you simply just replace the ongoing losses. So broadly 10 ml per kg we will give, replace the ongoing losses. Then we have plan B. Here pehle we have to rehydrate, so we give 75 ml per kg of ORS because the child is eagerly drinking, so I can give oral solution ORS 75 ml per kg over 4 hours. Along with that, replace the losses, that is 10 ml per kg. Right? On the other hand, in plan C, what will happen now? The child cannot drink. The child is very lethargic, so I have to give IV fluids. Ringer lactate we give, right? How much? 100 ml per kg. We divide it into two parts, 30-70. 30 ml per kg and then 70 ml per kg. So this, if the child is less than 1 year, you give this 30 ml per kg over 1 hour and remaining over 5 hours. In an older child, you give it in half hour and 2.5 hour, right? So this is about severe dehydration, rehydration correction, and along with that, needless to say, you have to replace the losses, ensure maintenance fluids that you have to do in all three, right? So this was all about dehydration assessment and management. And as I told you that in pediatric population, viral diarrheas are more common as compared to the bacterial diarrheas, so no antibiotics, right? And in all of these diarrheas, we supplement with zinc supplementation. If the child is less than 6 months, you give 10 mg per day, and after that 20 mg per day, and you continue this for at least 14 days. Right, so this was all about dehydration assessment and management. With that, we complete the 50 questions of your FMG Pediatrics Predictor series. Do check out the Predictor book. It's on great discount nowadays, right, because of the sale, the 6th year anniversary. And if this session was helpful, do check out other questions in that book. Very high yield questions, a very good strike rate overall, and I believe that would be a really a game changer for the people who are preparing for, students who are preparing for the FMG exam. Right, with that, I end up this session. Thank you for being so active throughout and being cordial throughout this session. We'll meet some other time. Till then, all the best for your exam, all the best for your preparation. We'll meet on the other side. Thank you.